It's one of the things on this year's ballot that could easily go either way, with latest polls showing undecideds could rule the day. A yes vote on question 1 would create patient assignment limits for all registered nurses working in hospitals and certain other healthcare facilities. A no vote would leave all relevant rules and laws in place. Right now, the only limit Massachusetts imposes is that nurses in intensive care can only have 2 patients at a time. But if question 1 were to pass, all nurse-to-patient ratios in hospitals and these certain other healthcare facilities would have limits based on the type of unit or patient a nurse is working with, and institutions could be fined up to $25,000 per violation. Judith Shindul-Rothschild is an associate professor of Boston College's Connell School of Nursing and former president of the Mass Nurses Association, the union spearheading the Yes on 1 campaign. Judy, good to have you. Thanks for being here.
Thank you.
Kim Stevenson is a research manager at the Massachusetts Health and Hospital Association, part of the No on 1 campaign. Kim, thank you for coming too. Let me start with you, Judy, if I can. I just explain, obviously, very briefly what question 1 would do. If you want to expand briefly on that, feel free, but much more importantly, tell us why question 1 is important for Massachusetts.
So for 20 years, Massachusetts members of the Mass Nurses Association have been trying to get a bill out of the State House that would put some limits on the number of patients assigned to nurses in units other than the ICUs. It's gone nowhere. So this year, the nurses decided to collect 100,000 signatures, the 24,000 members, and put it on the ballot for the citizens to decide.
But why do we need it?
Well, because we've had since January over 2,000 unsafe staffing forms submitted by nurses in Massachusetts hospitals who are assigned too many patients and who are concerned about the safety of those patients.
Tell us, Kim, why a no vote is what is correct for Massachusetts, and do you believe patient safety is currently at risk?
I do not believe that patient safety is currently at risk. Right now in Massachusetts, we have some of the best hospitals in the country. We also have some of the best quality scores on measures across infections, mortality, patient safety, patient satisfaction in the country. In fact, Massachusetts hospitals have the lowest inpatient mortality rate in the country.
But how about these concerns that Judy mentioned that are voiced by nurses? You don't consider them legitimate or what?
Yes.
Yes, which? They are legitimate or they're not legitimate?
Let me explain.
Okay, sure.
So are there some units in some hospitals that might need more nurse staffing? Yes. And in fact, there's 1,200 vacancies right now across Massachusetts hospitals. These are nursing positions that they're actively recruiting for and trying to fill. One of the problems, and I'll get more into this later, is that there are not enough qualified nurses in the state to fill these positions.
Why don't we get into it now if we can? One
Sure,
of the things I've
absolutely.
noticed, at least from having read, it seems there's not only a huge divide on policy, there seems to be a huge disagreement on facts.
Right.
And one of the things I wanted to deal with was, is there a nursing shortage? And obviously that's relevant to consideration if we need more nurses or not. So make your case. There is a nursing shortage?
Yes. So right now, the whole country essentially is under a nursing shortage. In Massachusetts, we have some of the oldest nurses in the country. 50% of our RNs are over age 50, 25% are over age 60. We have about 4,500 nurses retiring each year, and only about 3,500 nurses graduating from schools each year.
Isn't there a question about the credibility of the numbers of the no side? Because what I originally read, if I may, is you originally said that there would be 5,000 additional nurses needed here, and the Health Policy Commission that you guys cite all the time says there might be as few as 2,200 needed. You're off by a factor of like 150%.
Yes, so I can explain those differences. So the Health Policy Commission did not factor in the 1,200 current vacancies, which we do include in our number of 5,911 nurses. And also they did not measure nurse staffing for the emergency departments, and that's in the report.
Okay.
And it's also for outpatient and observation units.
You don't think there is a shortage? You
Absolutely
think the nurses
not.
are there, wait, to meet the needs that would be established if this were to pass?
Right, and there is no nursing shortage. The surveys that have been done and analyses that have been done by the federal government show that Massachusetts is one of 2 states by 2030 that will have a surplus of nurses. We also have more part-time nurses than any other state in the country. So if we bring the number of, test 10% of those part-time nurses, if we bring those into full-time positions, plus we're graduating 3,300 new RNs every year, plus...
She says that's short of the 4,300 or whatever the need is.
so.
Yeah.
No, not if you add it up, because the number of part-time positions is 27,000. If you take just 10% of
They
that...
don't all work in hospitals.
These are nurses who work in hospitals. These are from the American Hospital Association, part-time nurses who work in the hospital. If you just take a small portion of those, equivalent to what the national average is for part-time nurses in hospitals across the country, you've got it.
They don't all
If I can, just for a second,
Yeah.
because this is the first of a number of areas where there's dramatic disagreement. Do you think the yes side is cooking the numbers, and do you think the no side is cooking the numbers? I mean, there's a huge disagreement
If I
here.
may. I'm not sure where their data is coming from. So we look at Department of Public Health. The Massachusetts Department of Public Health does a biannual survey.
So you think they're making this stuff
I
up?
don't know. I'm not saying
the
she's
Health
making it up,
Services
but I'm not
Research
sure.
Administration.
But a
Health-
surplus in 2030 is not going to help us January 1st, 2019.
No, that's by 23. We have a surplus all the way through. The Health Policy Commission included this in their report that they just published last week.
Yeah.
And David, Dr. Arbach, who's on that commission, he's done some of the best surveys on this. This region is going to have a surplus. I also want to say I'm the advisor for the Massachusetts Student Nurse Association, which supports question 1. The National Student Nurse Association does a survey every year of new graduates, how long it takes them to get employed. The hardest region, the toughest state to get employment is Massachusetts. So
Can we move to another issue, which is a huge issue? Here are at least the highest profile competing numbers on the cost of this thing. If we can put this up. A study you did estimated that it's well short of $100 million, some in the $35 to $47 million range. An independent state agency, the Health Policy Commission, which we've now discussed a few times, said it's somewhere from 676 to almost $1 billion. Why should people at home find your numbers, which are infinitesimal next to Health Policy Commission's, more credible than theirs?
So I use publicly available data, and the Health Policy Commission has a table that outlines the differences between all of our studies. So I didn't have access to all of the units with data that they
So does that mean your number's wrong?
So my number, actually, when I estimated the percentage of increase, is exactly where the Health Policy Commission came out. I said we'd need to increase the number of nurses by 2 to 7%. That's right in the range.
You have to explain to me better then, how are you in the $50 million range and they're in the almost $1 billion range,
So
if you're talking apples and apples?
Well, my $47 million was based on actual wage rates for those nurses, and when I calculated out how many extra nurses are we going to need, and then I attached the wage rates for that, and then I said, I don't have access to this information, multiply that times 3, and then you're
so
in the
if you
range.
did have access to this information, your number would grow.
Absolutely.
To what? What's your new estimate?
So it would be right where the Health Policy Commission
So
is.
you agree with their number?
In terms of the number of new nurses, yes.
No, do you agree with their
the cost.
676?
The cost, no, because
What's your new number on cost based on the additional information you have?
I would say that it would be around, I would multiply my 48,000 by at
Million.
least 48 million by at least 3.
So it's at least 150 million.
At least 150 million.
Two other things.
The
If
state
they're right,
alone
if I
has
may, just for a second, if they're right and the number is higher, is in the 7, 8, 900 million, would yes on one still urge people to vote yes? If people believe the Health Policy Commission numbers, is this important enough to spend $1 billion on?
So when you look at the hospitals that meet the standard right now in question 1 versus those that have the worst staffing in the state, on average, the hospitals that meet the standard got a reward from the Centers of Medicare and Medicaid Services of $500,000
But what's the answer
each.
to my question?
The ones that have the terrible staffing get hit with a $500,000 penalty. The hospitals with the worst staffing are getting hit with $500,000 in penalties from poor patient outcomes every single year. They're drowning in debt because they don't have the nurses.
But my question is, regardless
outcomes.
of cost, you think this is important, regardless of what the ultimate bottom line is, you'd still urge a yes vote. Is that correct?
Because it's going to improve patient outcomes and cut down on mortality.
And is
Yes.
it not true, is it not fair to say, Kim, that you would oppose question 1 even if Judy's numbers were right, even
Yes.
if it was $50 million?
Yes,
So
because-
it's not about cost. It's because you don't want anybody telling administrators how to assign nurses. Is that a fair statement?
Let me say this. Nurse and patient care is not cookie cutter. Cookie cutters are for baking. You can't apply the same ratios and the same staffing needs and patient care needs to Boston Medical Center as you do to Athol Memorial Hospital. The needs are different. Community hospitals work on smaller budgets. They have different patient care needs. They send their more critical patients to the academic medical centers.
But the answer to my question is, regardless of what the cost is, even if it was $1 million, you don't want the state. Is that correct?
That is correct.
Okay, can I get back to the community hospitals for a second? One of the issues here, I don't know if I assume you'd admit, some of the big hospitals, they're turning a profit, can probably live with this. They don't like it. I mean, they live with it financially. Some of the community hospitals, I've heard say, it's going to cause them to shut down parts of their critical parts of their units. Is that made up in your estimation?
So the hospitals that I found had the poorest staffing actually have millions of dollars in profits, every single one of them. Most of that group are for-profit hospitals. One of the members of that group, Bay State Medical Center, has the second highest level of profits in the state right after Mass General.
How about the smaller hospitals that have been complaining like crazy about this, saying they can't sustain the additional costs?
So when I looked at comparisons between California and Massachusetts, what California did and what actually Dr. Stu Altman said at the hearing,
Health Policy Committee.
The way the California hospitals managed this was they increased the proportion of their total personnel budget and devoted more to nurses and direct care providers and less to administrators.
Okay, let's hold it there. You're shaking your head no. Where's that? By the way, we should say for the people at home, the only state that has anything even remotely like this is California. What's your assessment of what we've learned from California?
So California, through the legislation, not a ballot proposal, signed this into law in 1999. The ratios did not go into effect until 2004. They had 5 years to implement. But regardless, California is not Massachusetts. Completely different patient population, different financial situation. They also allowed waivers for small and rural hospitals, which the M&A's ballot explicitly prohibits the HPC to do.
Why should there not be waivers for hospitals that could prove to an independent entity? I mean, interesting, the Health Policy Commission, you say whose numbers are elevated, is the same organization that in your ballot question you want to oversee and enforce this thing. So obviously you trust them. Why isn't there some flexibility here, room for compromise, where there'd be some waivers if a hospital could demonstrate that the cost of this ballot question would cause them to have to shut down certain important services that you'd both agree they need to do? Why no waiver rights?
So the ballot question says that the hospitals have to have a plan. They have to have a plan for how this is going to be implemented. There's also language in the ballot question that none of this takes effect in any hospital with an M&A contract. 65% of all the nurses working in Massachusetts hospitals are covered under an M&A contract. They've already met with the hardest hit hospitals and said, we will extend those contracts 3 years to give people more lead time.
Kim, can I
interrupt here?
Of course you can.
This assertion that some hospitals right now are meeting these ratios is just not true. And the reason why is because this ballot, the rigidity of this ballot that we are opposed to is that it's at all times. We're not basing it, the ballot is not based on averages. So right now, yes, if you average...
I thought the Health Policy Commission did say that some of the ratios that are being established in the ballot question are actually exceeded already in certain settings.
On average.
On average, okay.
So that's very different than saying at all times. So at all times means 24 hours a day. If a nurse goes to transfer a patient to another unit, if a nurse goes on break, you have to have coverage. So you have to have a built-in additional 10 or 20% of nurses on staff just to meet those ratios at all times.
I want to ask a quick question about the California experience. At least my reading of the analysis is that the report suggests that patient outcomes, there is no clear difference in patient outcomes, but there is a clear difference in terms of job quality for nurses. Why is that alone not something that matters, improved job quality for the men and women who do the service?
I absolutely agree that job satisfaction is important, and let me tell you that the research that the M&A cites by Joanne Spetz, who was part of the research, in her study, and she did find improvement in job satisfaction for RNs, but it did not correspond directly to where the gains were the most. And there was also another study by Peter Bierhaus that looked at trends over the same time period nationally. Nationally, job improvement or job satisfaction for nurses was increasing
I want to hold
at the
it there.
same rate.
Do you agree that at least out of California, this study that you cite says that there's no clear difference in patient outcomes even after those nurse-patient ratios were put into place?
There absolutely is a difference in terms terms of patient outcomes, and the Spetz article says that there was a difference in mortality. Dr. Linda Aiken and Dr. Matt McHugh also point to differences. My research, if you look at what studies have been done to compare California and Massachusetts, there's 6. I've done 4 of them. No. There's a difference in terms of patient outcomes due to nurse staffing.
Can we talk about our own example? I forget California, the ICU, intensive care that we mentioned.
Yes.
We mentioned here. Did you agree to that? That was a compromise through the. You agreed to it. I mean, you personally.
Yes.
So if setting ratios by statute is such a horrible idea, as you told me at the beginning of this, why did you agree to set ratios by statute in intensive care?
I would love to answer that. So
that's why I asked.
In ICUs, hospitals were already generally staffing at the 1-to-1 or 1-to-2 level. However, there have been unintended consequences here in ICUs, and in fact, a study was just published in September by researchers at BID and Boston University that found there were no improvements to patient outcomes based on the law, and they cautioned policymakers in that study against setting these
Isn't that
more
true? By the way, I
widespread.
read a summary of that Beth Israel Deaconess thing too.
Yes.
Said no impact on mortality in the ICUs.
So I just sent the Health Policy Commission a different analysis. Number 1, they only looked at 3 hospitals. Number 2, they didn't look at differences from when the actual numbers of patients to nurses in ICUs dropped. That didn't drop significantly until 2017. There are 2 papers that accompany those articles, critical of them, one from a physician, one from a nurse, talking about how you have to go further out before you can make any conclusions that this law was ineffective. The number of patients to nurses hadn't even dropped by this point. So I looked at the latest data coming out of CMS, the latest staffing numbers, and in fact, in the hospitals where they did drop the numbers of patients to nurses in ICUs, the CAUTI rate significantly declined. And we're going to do a paper on that and submit it, but I gave all of that data to the Health Policy Commission so that they could look at it and say, see, it did make a difference in terms of this outcome.
You want to quickly respond to that, Kim, please?
Yes, please. So there have been over a dozen primary studies of California looking at pre- and post differences before and after the ratios were implemented. Joanne Spetz, who has studied this issue in California more than anybody else and has published with Linda Aiken, she said at the Health Policy Commission there's no evidence of systematic improvements in patient outcomes. And many nurse researchers, most nurse researchers in fact, including Linda Aiken and Matthew McHugh in a 2012 study about safety net hospitals in California, caution that these widespread policy mandates are basically a sledgehammer to a very complex problem.
Can I summarize something, because we only have a minute and a half left, and I want people, because there are a lot of disagreements, I want a couple of things I think we did establish, and I want to reassert them so people go home with that. You were acknowledging that even if you are wrong, the yes on one people, on the cost, and it's higher, that you think the setting of these standards is important enough
Absolutely.
that regardless of the cost that should happen.
And it makes economic sense and safety and quality sense.
And you were saying that even if the cost was negligible, not the billion, because that's all that's been in the news lately, even if the cost were not $1 billion, even if Judy's right, you'd oppose it because you don't want the state, you don't want any statutes
it's too rigid.
Telling you what to do.
You can't have the same staffing requirements at every single hospital and take away judgment from the professional nurses who are in the moment.
Okay, we literally have 60 seconds left. You have 20 seconds to make your case, and then you have 20 to make yours. Please, Kim.
You can't apply a rigid staffing mandate to patient care that changes on a minute-to-minute basis. You need the flexibility for nurses to use their professional judgment to be able to determine in that moment, I need to take care of this patient, I've got that patient coming in, and you just have to make those minute-to-minute decisions.
She wants a no on one. You want a yes on one.
I want a yes on one.
Please.
The standards come from professional standards from professional nursing and medical associations. So these standards should have been applied already, and they're being ignored. That's number one. Number two, there's an acuity scale that accompanies this, so that exactly we would do that. That's one of the mandates. We had an acuity scale in the ICU law. We have an acuity scale in this so that the special, unique needs of each patient are taken into account in terms of the nursing assignment.
Judy, thank you very much for your time. Appreciate it. Kim, same to you. Really appreciate both of your coming and putting your 2 cents in. For more information on question 1, 2, and 3, please check out WGBH News' Plain English Guide to the 2018 ballot questions. It's on our WGBH News election page. That's WGBHnews.org/election 2018. And once again, Election Day is 2 weeks from today, November 6th. Be sure to join us next week for the only lieutenant governor debate between incumbent Karen Polito and Democratic challenger Quentin Palfrey. That's Monday, October 29th at 7.